Good afternoon, everyone. I'm Jaime Sepulveda. Welcome to this COVID-19 series organized by the Institute for Global Health Sciences. This first one is on contact tracing, and we have a wonderful group of speakers. Without much ado, I just want to introduce Mike, Reid, and Jess Celentano that have been working very intensively with a group of colleagues from IGHS in contact tracing and testing. I know our clinicians, health workers, doctors, nurses are doing fantastic work in our medical center and hospitals, but I also want to recognize the amazing work that this group of faculty, staff, and students are doing in testing and contact tracing. You guys are real heroes. So my recognition. Mike, take it from here, please.
Thank you, Jaime. Those are kind words. So my name is Mike Reid. I'm a faculty within the Institute for Global Health Sciences, and a team of us are going to share our insights from the contact tracing work that we have been doing in partnership with San Francisco Department of Public Health. Contact tracing is one of those key things that we believe has to be implemented at scale if we're able to move beyond shelter in place. And we hope to describe to you some of the programmatic elements that we have been involved with supporting San Francisco Department of Public Health to implement a robust contact tracing capability. Jaime was kind to laud praise on our team, and they've done a phenomenal work. But I also just want to pause and just say that part of the reason why San Francisco is in such a strong place right now in terms of its response to the COVID pandemic really reflects the phenomenal work of our public health leadership in San Francisco. And I am especially grateful for the decisive decision-making and strategic management that folks like Tomas Aragon, Susan Phillip, Grant Colfax have played in this moment. I think I have 5 minutes to give you 5 slides on contact tracing and a 5-slide overview, and then I'm going to hand on to my colleagues who are going to go into a little bit more detail. So the first slide, what is contact tracing? Contact tracing 101. So very simply, the idea is that if we're serious about getting a handle on this epidemic, then not only do we have to test everybody that's symptomatic, we need to find everybody who's suffering from COVID-19. And then in addition, we need to reach out to all of their contacts, recognizing that people who have been in close contact with an individual who are suffering from COVID-19 are particularly at risk for developing symptoms themselves. So the quicker we can reach out to contacts and tell them, hey, you've been exposed to COVID-19, you need to self-quarantine, the more effective we will be at controlling the spread of this awful disease. And there's a fair amount of early evidence from elsewhere around the globe that contact tracing done at scale can have an impact. Certainly in Wuhan, China, they mobilized a team of 9,000 contact tracers to contact trace across a city of 11 million. And if the data is to be believed, they had a phenomenal impact. Second slide. So the second thing, though, when one thinks about how one does contact tracing is to appreciate the need to scale. In order for us to be able to reach all contacts, the magnitude of the response, both from a technological point of view as well as a human resource point of view, is pretty extraordinary. Tom Frieden, the previous director of the CDC, estimates that we need 300,000 contact tracers across the US if we're serious about doing this effectively. If you can just advance the slides for me, Robert. So in order to do that here in San Francisco, one of the first things that had to happen was we needed a scalable digital solution, something that would work, that was simple to do. Michelle Moghadassi is going to talk about that solution, and Michelle played a phenomenal role at SFDPH in helping them to implement that solution. In addition, though, the San Francisco Department of Health had to rapidly mobilize a workforce beyond the DPH. All of the DPH staff are fully activated, working on COVID-19. We needed more people. How did we do that? My colleague Jess Celentano is going to describe the efforts. And then finally, and this is a really exciting space where I feel like IGHS is going to play a key leadership role over the next 12 months, we needed to implement a high quality training program so that contact tracers were effectively equipped to do that. My colleague, Debbie Bain Brickley, is going to talk about the training piece. Next slide. So the thing to appreciate, though, is that contact tracing is not a silver bullet. In and of itself, it's not going to solve the problem of COVID-19. And even in countries like Singapore, which have implemented a very robust plan for contact tracing, we're seeing spikes in incidents, particularly in underserved communities, in immigrant populations in Singapore. I think this reflects the fact that it's not just enough to say, hey, you've been a contact of somebody with COVID, you need to self-quarantine. We need to provide those individuals with the wraparound services that they need in order to safely self-quarantine. And my colleague Susie Welty is going to talk about that. Next slide. So I don't know about you, but I really hate COVID. As a father, I hate the way that it has affected the lives of my kids and the fact that they're estranged from their friends. As a citizen, I hate the way that it's upended our society. And as a clinician practicing at San Francisco General, I hate the way that it is causing devastating disease. And I think one of the things that moves me most in San Francisco is how this disease is causing disproportionate amounts of deleterious impact in certain communities, and specifically here in San Francisco in the Latinx community. And I think we would like to think that contact tracing could be a means of redressing some of the health disparities. If we're able to effectively reach that community, resource them, educate them, then hopefully this can be an intervention that can enable us to move beyond this awful moment. My colleague Lucia Abascal is going to talk about the contact tracing and its role in reaching that population. So finally, in my last slide, I think one of the things that we are appreciating is that we have a lot to learn. And as an Institute for Global Health Science, we actually have a lot to learn from our partners around the world. Robert, if you could advance the slide. We're already seeing that many countries in sub-Saharan Africa are doing a great job of implementing contact tracing programs. And I think now is a time to really rethink how global health is done. Before COVID happened, a few months ago, there was a movement across IGHS to really think through what does it mean to decolonize global health. And I can think of no better moment than now to recognize that we in the US have a lot to learn from what others are doing more successfully elsewhere. So with that, let me hand over to my colleague, Michelle, who's going to talk about the digital or the informatics solution.
Hello, everyone. Thanks, Mike. So I'm Michelle Moghadassi. I'm an informatics program manager with the GSI team. And I'll just give you a really brief overview of some of the technology that we've been putting into place to help with this effort with the San Francisco Department of Public Health. Can I have the next slide? So just to give you a little background, we've been using the CommCare app that's built by Demagi. It's an app, some of you may already be familiar with it and have used it in other countries. It's in 80 countries, used on over 2,000 projects worldwide. Anything from ANC to malnutrition or infectious disease work, it has been used in a broad variety of efforts. It's very, very well suited for low resource settings, and even so it has a very simple back end for a lot of the work that it does. So here I'm showing our basic flow for the San Francisco Department of Public Health, and this is a very typical flow of suspected cases, and these may come from the communities or from a clinic or a provider, going to a person of under investigation, testing and consult, where they are being screened for further testing, and then the lab results coming into the system, and then going on to case investigation. And this will also trigger action by the community outreach hubs, which are groups that are going out to the community to further investigate either workplaces or places of worship, or childcare centers, educational institutes, long-term care facilities, a variety of other means where there might be a further contacts to look up. and then also to the contact tracing team itself. And you can get a sense of the portion that Demagi is working with, and those orange arrows are reflective of the communication and data flows that are going through the system. Can I have the next slide, please? So here, I apologize for the busy slide, but I just wanted to highlight the many different data integrations that are going on with the system. Although it's a relatively simple back end, it's able to do a lot of essential features that make the workflow very streamlined and allow for very rapid communication. And as Mike was alluding to, time is of the essence. So making sure we can find the results, get in touch with the cases, communicate what those contacts are to the contact tracing team and to the community outreach hubs. So some of the examples that we're using in the features are for the case investigation team, but as the interview goes through, based on responses they give, this will alert community hubs about what are some potential places they need to go and investigate, whether it's a workplace or other things, as I've mentioned. And then also it will give a guidance and referral for isolation and quarantine referral services. If people are saying that they're homeless or have food insecurity or need additional wraparound services, this is also triggering more information to social workers and social services. And then from the hub perspective, they are receiving these information, going out into the community, and then being able to elicit further contacts, which will then transmit and communicate down to the contact tracing team. The contact tracing team, as I'm saying, they are able to get it from both the case investigation and hubs and from multiple sources relatively seamlessly and very quickly, and also provide recommendation support. The app itself, based on algorithms, will provide a script for the tracers on guiding on self-isolation or self-quarantine based on their symptoms. And then furthermore, the app was also able to send out SMS and provide symptom monitoring over we've determined a 14-day period so that we can track the people if they were to become symptomatic or need additional services at any time. And now I'll pass it on to my colleagues for the next piece. Next slide.
You're on mute, Jess.
Jess, you're on mute.
Hi, I'm Jess Celentano. I'm the Deputy Director of the Center for Global Health Delivery, Diplomacy, and Economics, and I'll be speaking about building a workforce. So anyone who's been following COVID news has heard reference of building an army of contact tracers. The reality is that the workforce that we have right now is a far cry for an army. In fact, a report came out this week that there's approximately only 2,200 contact tracers in the United States, despite contact tracing being a cornerstone of epi investigation. And a recent report by Johns Hopkins that Mike referenced projects as many as 100,000, possibly 300,000 workers to make contact tracing effective. And it will require an investment of about $3.6 billion. And the head of the CDC, the former head of the CDC, thinks that that's an underestimation. So you can understand the scale of what we're facing. Next slide, please. So 3 weeks ago, which in COVID time, I think is about half a decade, the San Francisco Department of Public Health recognized the pressing need to rapidly scale the workforce dedicated to contact tracing, and they looked to UCSF to partner in this endeavor. So in order to kind of understand the workforce that we were projecting, we first looked at other countries and epi models to estimate that number. And as Mike also mentioned, in Wuhan, there were 9,000 for a city of 11 million. And you know, the formula, as you can see from this table, is not just driven by population, it's also a function of the number of cases, the ability of the case investigators who reach out to the cases to elicit contacts, and then the number of contacts per case, and then the efficiency of the contact tracers and the ability for them to actually reach those contacts. So there's millions of other factors that you can't necessarily stick into a clean formula, although I'm sure some of our biostatisticians here at IGHS are going to argue with me on that one. But you know, to be able to get a good estimate, we assumed about 100 to 150 people would need to be mobilized for a robust, sustainable workforce in San Francisco. You can go to the next slide. So what did that mean? What did we have to do? So we started by recruiting a staff within IGHS, within our core team. We realized very quickly that to understand the workforce that we needed to start by being the workforce, understand the pain points, understand the opportunities, understand the training needs. So we started doing the contact tracing ourselves, a small team, and then we recruited other IGHS folks, many of whom I imagine are on the call. And I say a big thank you to being the training guinea pigs to testing the system. And we knew in that time, though, that, you know, these people were steeped in public health. They knew, you know, kind of the tenets of what they needed to do to be able to do this work. And the workforce that we needed to mobilize, that we would soon be mobilized, which we have now mobilized, didn't know this. And so we had to really tailor the training needs. So what we did, we started with a diverse workforce of city attorneys, librarians, assessors, retirees, clinicians, as well as med students. And we now have 105 people onboarded. We trained over 240. We oriented over 400. And we're really working with those different cadres. We're understanding the skills that the city attorneys bring in investigation, the librarians in motivational interviewing, being able to ask the right questions people are thinking but not able to articulate, and assessors and, you know, being meticulous. I'm generalizing on, you know, cadres, but, you know, this is kind of what we're seeing, and really being able to wrap a training package around these people to make sure that they have what they need to be successful in reaching these contacts. And of course, we have lots of volunteer requests, and a thank you to Ritu for collating those. Next slide. We have a team structure that we've built. We're working now 7 days a week, 8 to 8 on the weekdays, 10 to 2 on the weekends, 3 shifts, 4-hour shifts. It's a lot of work, but we're really starting to see results from this. We're the composition of the team, you can see, and we just make sure that the team has a diverse language capacity, which is something that we're really working towards, that is key to staffing any contact tracing workforce. Next slide. And lastly, just the opportunities and challenges. Right now in this moment, there's incredible enthusiasm. We have a government workforce due to shelter in place and the disaster emergency protocol. They are able to be mobilized for this. And we're able to see talents from different cadres. And of course, we have IGHS, which we're so grateful for. In challenges, you know, making sure that language is representative of the people that we're trying to reach. Sustainability, that this is, you know, that we have a plan in place for when the government workers are brought back to their jobs. The ever-changing landscape in testing and treating, and where testing sites are, and how people get and access resources is always changing. So making sure that we're evolving our training and making sure we're retraining people for that. And then of course, making sure that people understand, you know, this is exciting right now. This is something to invest in, but this is not a sprint. This is a marathon. We're going to need a workforce dedicated to this, not for the next couple of weeks or months, but years. And thank you. I'll turn it over to my next colleague, Debbie.
Hi there. I'm going to be talking about the training and onboarding process. My name is Debbie Brickley, and I'm the Deputy Director of Training and Education at GSI. I want to start by calling out the training team members, Andrew, Cheyenne, Solange, and Jess, and myself. But I also want to call out all these other people, 20+ trainers who've been called upon, sometimes at just a moment's notice, to create content, to facilitate training sessions, to create a practicum. They've been incredible. Looking at some of our numbers, we have already done more than 18 individual training sessions since April 5th, and including this morning. And that includes multiple sessions for different waves of contact tracers. We've trained team clinicians. We just yesterday did our first training for case investigators in collaboration with SFDPH. And we're open to doing other types of training as well. That has added up to more than 32 hours of training offered so far. I mentioned 20+ trainers, and I just rough calculation thinking more than 160 person hours by the trainers. Next slide. So I just wanted to give a brief overview of what the training for a contact tracer looks like right now. And again, this keeps changing, we're improving. Every wave of trainees is a little bit different. But generally, this past wave, it's been 2 days of 3 hours sessions that are more focused on the didactics and learning about the epidemiology of COVID, what contact tracing means in the greater containment response, the nitty-gritty of how to do an interview as a contact tracer, and how to use the tracking app and the phone, or just an introduction at first. And then on day 2, we get a little bit more into the softer skills of interviewing and building rapport and having cultural humility, issues of confidentiality, and how to refer contacts for testing and other social services. And they do an asynchronous HIPAA training required by SFDPH. But then as the days go on, it gets a little bit more high touch. So they learn about enhanced contact tracing, for example, for workplaces and priority contacts. They see a live demonstration of how an interview is done using the various technologies, using an actor. And then they get their hands onto the apps and they get to log in and navigate and see how to use them. And just today, for the first time, we brought in a team clinician and a team lead to share some of the issues that they see when working with contacts and what they're looking for and how to make best use of those resources. And then they transition into working a shift, but initially shadowing an experienced contact tracer so they can see what it all looks like with a real contact. And then they can make their first call when they're ready, being shadowed by someone who can offer tips after the call. And we've developed a number of different materials that I've listed here, and I won't get into them. But you know, we have used quite a few different methods. Zoom is our friend, but Zoom has a number of different features. So we've done breakout sessions for role plays and group discussions. We have quizzes and opinion polls to get people, all of this to get them more involved and interactive. And then we have our technical people offering TA for using the apps. And so far, our evaluation has been a pre-post quiz to see if they've learned the content. We look for their feedback on how we can improve our training. And we've just developed a quality assurance checklist of, you know, how each new contact tracer that's brought on can be evaluated and how they can improve. So we're still working on that piece. So I think that's the end of mine. I can pass it on to my next colleague, Susie.
Hi, my name is Susie Welty. I'm the Deputy Director for Surveillance in the Global Strategic Information Group, and I'm going to talk about the services beyond just contact tracing. So as we know, contact tracing alone is not enough. We need to support the contacts. We're asking them to do difficult things like isolate and quarantine for 14 days. And as Lucia will talk about, for many of these, many people, these are Latino community, a lot of the Latino community who are essential workers who are also living sort of paycheck to paycheck. And so asking them to stay home for 14 days is a big deal, and they may not have enough food or supplies to really last that long. So I'm going to talk a little bit about what the San Francisco Department of Public Health has done to support these populations and making sure that they can comply with what is being recommended. And the supports include help for quarantine and isolation, testing, and access to social services. Next slide. We call these wraparound services, and I really like the visual image of that. And it really has been a commitment by SFDPH to facilitate people doing what is necessary during this pandemic. It's comprehensive support. So I'm sure we've all heard of the homeless, the epidemic within the homeless population, and obviously it's impossible for them to isolate or quarantine when they're living on the streets. In addition, many families, you know, I've talked to families who live 20 in a house in San Francisco because each family rents a separate room in a 5-bedroom house. They share a kitchen, they have maybe 2 bathrooms, and in these circumstances, it's impossible to isolate yourself. And that's where this health department has really stepped up and provided hotel rooms and places where people can safely quarantine and isolate. In addition, food services are available for those that don't have food, and they deliver food, and they've done a great job of really trying to match the need in terms of cultural types of food that people may prefer, and what kind of cooking services, cooking areas they have available, whether they have a full-size fridge or microwave, really going into the details. In addition, cleaning supplies, we're asking them if they're sharing a bathroom to clean the bathroom very well with the disinfectants. If they don't have those, they're delivered. Medication support, if they need support in prescription medications, we don't want them going to the pharmacy, so people are able to drop those off, and then other services for people with addiction and substance abuse. Next slide. And as I mentioned, the homeless population is one of our most vulnerable in San Francisco, and providing places for them to safely isolate and quarantine has been a priority for SFDPH. Next slide. And this is just an example of a press release from the mayor's office indicating the food service support for persons. And I think this, as Mike mentioned, this really speaks to the strong leadership of the city, both the mayor and SFDPH, in supporting everyone, especially vulnerable populations, through this epidemic. And I'll pass it over to Lucia. Thank you.
Hi, so I'll be talking about vulnerable populations, and I recognize there's other vulnerable populations in San Francisco, but right now the population that has the most burden of disease is the Hispanic and Latinx community. I'm working as a team clinician, but also as a contact tracer when they need somebody a Spanish speaker. So I'm gonna go into a little bit how is this disease affecting the Hispanic and Latinx community in our city. So here, as we can see, most of the cases are happening 31% in Hispanic or Latinos, but also to recognize that we don't know the race ethnicity of 24%, so that number could be higher. And this is important, even though these are cases, this translates in a bigger number of contacts that are Hispanic or Latinx. And we can see that almost 40% of the contacts we are calling, their preferred language is Spanish, and 46% identify as Latinx. It's important to recognize that these inequalities we're seeing in COVID are not happening in a void, and they're just like the tip of an iceberg of inequalities that have been going on. So housing inequalities, unemployment, and other things this community has dealt with. So it's important to point out some risk factors this community is experiencing. So as Susie was pointing out, there's a lot of families living together. So what we're seeing is bigger households and bigger family units when it comes to this population. Also, many of the people in this community are considered essential workers, so they're more exposed than maybe a white male who's working in tech and can work from home. And other conditions such as diabetes or other comorbidities are also seen in an increased rate in this population. So that also increases this population's risk for COVID-19 and severe disease. Next slide. So as contact tracers, we're trying to cover this gap. We have Spanish-speaking contact tracers and some team clinicians in each shift. We found that having the interviews done in Spanish works better than having a translator online. So I once called a contact that had been somebody else tried to contact them with an interpreter, and the contact never understood why there were 3 people on the line. So I think it's very important that we consider cultural barriers when we are trying to get these people to to talk to us. It's also important to consider that we might be the only access to healthcare these people are getting. So we might be that link between getting tested, between getting food services, because that's something else we've seen in this community. Many of them have been fired or furloughed or just are not receiving an income. So food insecurity is increasing in this population. And there's other issues to consider. So there's like a need to protect from possible scams. We know this population and other vulnerable populations might be susceptible to scam calls. So just to be sure we let them know that none of their private information is going to be asked. We're not going to ask about their social security number. We're not going to ask about immigration status. And some of the worries I've come across is access and navigation of healthcare services and employment. So, yeah. And I don't know who's next.
Oh, that's me. It's Karen. Hi, it's Karen White, and I'm the Deputy Director of Country Programs at GSI. I'm going to talk a little bit about lessons learned and maybe where we go next. So so Hannah Park found this quote for me, but I think it's a really good one from Bill Gates just last week. The normal health service staff can't possibly do all this work, even if the case numbers are fairly low. Every health system will have to figure out how to staff up so that the work is done in a timely fashion. And all these people will need to be properly trained. So hopefully we come in. So if you turn it to the next slide. So I just want to restate, I know Jess mentioned about COVID time, but it's been a month, maybe even less, that we've kind of jumped in and offered assistance to the San Francisco Department of Public Health as they sort of build up this model for care that's been amazing. Like the San Francisco model and all of the wraparound services is really, you know, one to strive for. And as we've kind of been a part of this, we at IGHS have rapidly developed skills and content to support COVID containment. And things include like the materials, the SOPs, the FAQs, the scripts for contact tracing, case investigation, the training materials and experience training people, the slides, the videos, the role play, but more than that, in the mentoring kind of aspects that Debbie talked about. Clearly the skills of doing it, we've actually, in the time we've been teaching it, we've been building it up. Our people, 44 of them from IGHS, have been team leads, contact tracers, clinical leads. We've learned how to do referrals to testing and services and all that. We've had hands-on experience with the technology and the Demaji app customization, working with Ring Central Call Station. Clearly, just with the workforce mobilization we've been working on, monitoring and evaluation of these and other containment activities, cascades and dashboards, developing a QI checklist and other ways that we can see if the people that we're training make sure that the quality of the interactions they're having are what we intend. So I can't believe we've done all this in, you know, a month, but it's a tribute to the team that's working on this. Sometimes Mike will come to us with a great idea of a way that we can help support SFDPH, and Jess and I will look at each other and we'll go, oh my God, how are we going to operationalize this? And then the team will just step up and it'll get done. So it's really a tribute to everyone. So if you turn to the next slide. Opportunities. So because we've had the opportunity of working with SFDPH in this area, and we've kind of learned what a model COVID containment program might look like, we are in a position to kind of leverage some of the things. There is a high demand for the skills and expertise that we've developed. So thinking about a UCSF learning platform for epidemic response that goes beyond sort of these kind of skills and maybe thinks about training in Epi 101 or outbreak investigation, et cetera, as we try and build that workforce that Bill Gates talked about more generally. So how can we collaborate? We've been approached by a lot of other health jurisdictions within California and outside of California wanting assistance in training contact tracers and case investigators. So we're looking at some of those opportunities. and then beyond just training these people in some general skills, they need to go to an infrastructure where they can implement these containment skills. So can we also be a bridge from, trained folks, create our own epidemic response team and work to customize some of these solutions actually at the health jurisdiction level? Is there additional research around non-traditional workforces and technology or any of the other areas that we're looking at through some of these activities? We're pursuing some of those as well. Clearly, we've had to engage in new partnerships. There's been other training centers at UCSF. The California Prevention Training Center has worked very closely with us in doing this as well. So working with other partners within UCSF, working closely with DeMoggy to kind of implement this solution and other tech partners. Is there the possibility to expand some of this work globally or learn from what they're doing globally, like Mike talked about? And then the possibility of expanding beyond the end of COVID-19. So post-pandemic global health recovery, training, TA, vaccinations, et cetera, and then building capacity. So we hope that some of this, this is an opportunity right now to actually build the capacity, with the funding and the drive and the need right now, but we don't want to stop here. We want to continue on and build the capacity for the next epidemic. So with that, I will turn it back to Mike to close.
Thanks, Karen. And just as an illustration of the tempo with which the team has been working, we got through 7 speakers in record time. But maybe I just wanted to end with a pause. I think if we zoom out and think about the American or the national response to COVID, I think it's probably characterized by obfuscation, miscommunication, incompetence, misanthropy. And in the midst of that, it's hard to kind of think through like who is leading in this moment. And I think I come back to why I'm in San Francisco as an HIV doctor. So I choose to do my infectious disease fellowship in San Francisco because San Francisco was a place that had a reputation for leading in the charge against the HIV epidemic 30 years ago. Gay men suffering with AIDS were vilified and stigmatized, and San Francisco was a place that stood as a model for how to deliver compassionate, patient-centered care. The first HIV clinic in the country was here in San Francisco. Some of the first clinical trials were done, and I don't need to tell people here about who all the global leaders in HIV have been over the last 30 years. They're people that have come from San Francisco. And so as I look to the future, in the midst of like the tumult and tragedy of right now, I do think like we as an Institute for Global Health Sciences and UCSF as an academic training center have a tremendous role to play in partnership with SFDPH to help other jurisdictions across the US out of this moment, and in humility to work with our partners around the world to come up with better solutions to address this pandemic. Let me just end with one other slide, if I may. And I just wanted to say a final thanks. Just advance for me, if you will, Robert. Well, one more animation. Well, I have Uzma here. All of you that are in the Institute for Global Health Sciences will know that Uzma Khan is our Director of Staffing and Strategic Operations. But the reason why Uzma is here, and if you just advance, Robert, is because Uzma Khan played an instrumental role in recruiting all of these amazing people. If you're faculty, you should just be so proud to have these folks on your teams. These people have worked incredibly hard, 60 hours a week, like just the most professional bunch of people that I've ever had the privilege of working with. And I think right now we as an institute can really just be grateful that we have such incredible talent to draw on for moments like this. So I think we're going to end there, Jaime, and hand back to you and Colin. And if there are questions, the team will be happy to try and answer them.
Thank you so much, Mike. That was a fascinating talk. 7 very talented people giving very concrete but fascinating descriptions of the work. I learned so much that I would like to ask you and the rest of the team, Mike, to be prepared to have the UCSF town hall on Friday, either this one or the next one, to describe the work on contact tracing that you guys have been doing. So this is absolutely marvelous. Congratulations. I want to echo Mike's comments on San Francisco as a model. In the HIV time, San Francisco became the model not only for technical competence, but also for social compassion. And I think in COVID-19, this is being demonstrated by this team again. So we have many fascinating questions, and Colin will kindly lead us through the Q&A session. Colin?
Yeah, thank you, Jaime. I appreciate the panelists, and thank you in advance thank you for your presentation, and thank you also for answers to the many wonderful questions we've received. A few have already been posted and answered in the Q&A box, so people can repeat that. But there were a few others that, rather than answer by writing, we wanted to pose back to the group. First, a set of questions around basic numbers. I mean, how many people have we been in touch with? And is there anything you guys can say so far about the composition of the people that have either been infected or the people that we're contacting as contacts of those infections? Are they housemates? Are they family members? Any generalizations you can make, Mike, or others?
Yeah, I'm happy to take that one, although Jess knows the numbers too. You know, as of Friday, we'd reached out to just over and made contact with 500 contacts of cases. In terms of the characteristics, we know that the average number of contacts that an individual case has is about 3.5 right now. An average number of household contacts is 3. Really, that we think that just reflects the fact that everybody is sheltering in place, and we recognize that that number is going to bloom as we move beyond this moment. Lucia highlighted the fact that there is a large plurality of contacts that are Spanish speaking, many monolingual Spanish speaking. But I would say that in terms of absolute numbers, we're not at a point yet where we feel like we can demonstrate impact. We are very keenly aware that we're still onboarding a large workforce. They're still learning to do that, and we're struggling to keep on top of the number of contacts that are being elicited in the case investigation workflow. As we expand, our hope is that we'll be able to keep a better handle on that, and more importantly, to be able to rapidly reach every contact, ideally within 24 hours of that contact elicitation process. But we're not there yet. I think come back to us in a month or so, and we'll be able to give you a better sense of the numbers.
Great, thank you for that. I guess there are also some questions about the sort of challenges, the typical challenges one encounters with these folks. And I know that's been spoken to. I'm wondering if you'd like to elaborate on maybe concerns that they may face in terms of answering honestly, concerns about privacy and other factors associated with that.
Yeah, I'd love Susie or Lucia to answer that, because I think they have some insight.
Yeah, thanks, Mike.
Yeah, Susie, go ahead.
Okay. Lucia and I, both as Spanish speakers, end up talking to a lot of Latino families. And as we mentioned, the economics of the situation are very difficult for them. You know, being isolated from their families, they're often, if they're the sick ones, they're taken from their houses and put in hotel rooms. So that's also difficult. I think access to healthcare has been difficult. And I think, you know, all around the situation is difficult for all of us, but people who are concerned about whether they have a job or whether they're going to be able to afford things. And then we're asking them to stay home, especially ones that are asymptomatic. So I've talked to people, a man that works in a food packaging plant with 200 other people, and I was asking him to stay home for 14 days, even though he felt fine, and, you know, forego a paycheck. And that's obviously a very difficult decision for someone to have to make.
And I would like to just add, so I think at the beginning, speaking with this population, the question around immigration came up a lot, but I don't know for you, Susie, but at least for me, I've never had somebody, I think that reflects on the how safe they feel in San Francisco as a sanctuary city. Nobody has any questions around their information regarding immigration. And even though they do have questions around unemployment and just access to healthcare, there's this sense of gratefulness, and they realize that we're trying to help and that we're doing this for them, their families, and their communities.
Thank you, Lucia. That's very helpful. There was another question around barriers to scaling up at this stage. I mean, obviously, you guys have done a tremendous amount of work in a very short time to mobilize a workforce and enable the training. Kind of, what do you see as the main barriers between where we are and where we need to be? Is it about recruiting? Is it about funding? Is it about policy? What do you see as the barrier?
I can certainly give an answer, but I think Karen and Jess probably can give you a more granular answer. I think one of the pain points for us is just getting a workforce that don't know public health mobilized quickly and onboarded is probably the biggest thing that we're faced with. I don't know, Karen, whether you want to add anything, or Jess.
I mean, I'd add a little bit of the technology platform, because we're building it as we're doing it. So we started on this Qualtrics survey mechanism, and then we're moving over to Demaji CommCare. And every day we think, oh, it would be so much better if we could do this, or, oh, we're not, assigning contacts very well. Like, we need to do this and that. And our call center is not perfect yet. So we're still working with a lot of technology barriers to really being more efficient in the job, that I'm hoping we're going to come up with solutions to. And of course, funding is always very helpful. We put everyone at full speed onto it, really just to, I think there's three things. You can have it fast, you can have it good, or you can have it cheap, right? So we're trying for fast and good. So anyway, maybe just.
Makes sense, thanks. A related question, not just scaling up locally, but also the dissemination plan. A number of questions have been asked about, well, where can we take this? If the San Francisco model for HIV was really the model that got exported to other places, is there an analogous dissemination plan, maybe first locally to other counties in the Bay Area, across the state, across the US, but also internationally? And I'm wondering if you guys have any thoughts about the portability of the interventions and what it might take to actually take it to other places.
Yeah, I mean, look, I think we're hungry to do that, Colin. I think the vision for a pop-up online academy of pandemic response training from hosted by UCSF that reflects some of these core tenets of the SFDPH model, but also builds in like the UCSF reputation for high quality education and training is definitely something we would love to share. We're also just keenly aware that there are other people doing this better, and we want to learn as quickly as possible from our global partners. As I said at the beginning, I think now is a chance for us in the US to really reflect on what we've done wrong or not as well as we could have done in this moment. And I think that's another piece of this, is to sort of think through what are the ways that we can learn quickly from our global partners so that we can all move beyond this moment.
Okay, great. Thank you for that. A couple of questions about volunteering. Do you guys need volunteers? There are people on the call who have expressed an interest in getting involved, both in San Francisco, but also perhaps in other locations nearby, either UCSF folks who are in other counties outside of San Francisco, or even down south in LA County. Any advice for how people can get involved and volunteer, either with you or with other public health agencies?
Jess, should they send an email to you? Poor Jess has been overwhelmed with like emails offering help, which is a lovely thing to receive. But right now we've sort of maxed our capacity for volunteer workforce. And actually, I think like we want to be thinking about like a sustainable model that doesn't rely on volunteers. And so I think that's a conversation that SFDPH is kind of thinking about. Where do they mobilize a sustainable medium-term workforce from? I'd love to imagine that there are community college grads that could jump into some of this work, or some of the promoteras or other groups that are in San Francisco who could get paid to do this. But that we're not there yet right now. I mean, I think sort of nationally or in other jurisdictions, I think reaching out to the Department of Public Health in that setting and say, you know, who's doing this? Can we support you to do this? Would be a key thing. What we're learning is that contact tracing, it does have to be sort of differentiated to an individual setting. A call center in the middle of Omaha isn't going to meet our need. It has to be people trained that understand the local specific requirements.
Great. So again, I think you know, the need for like a multi-local kind of operation where it's tailored, where it leverages the technology and the training, but is very much customized in terms of workforce, is probably going to be the answer that scales best. How long do you think we'll have to do this, Mike?
I mean, I think maybe till we have a vaccine, right? I think like we're going to have to continue to identify every case, reach out to every contact, and more importantly, I think build up a public health infrastructure that can provide the kind of wraparound services that Susie talked about, so that vulnerable members of our community aren't at risk, period. And I think that, you know, contact tracing and case investigation is key to that. But I also think we need to sort of expand our vision for what public health looks like in San Francisco and beyond, up until a point where we have a vaccine. And hey, even when we get to that point, this seems like a good investment for the long term. Let's reimagine public health for San Francisco and California beyond that moment, so that 20 years down the line, we don't have to respond in this kind of way.
Yeah, one can almost imagine the contact tracers, maybe this is a reach, but almost evolving into something more akin to community health workers in other contexts.
Absolutely. And I think, and also like, if we're serious about ending this epidemic, we have to address, you know, the determinants of homelessness and why members of our society are excluded from healthcare. And I think those require inherently political policies to be made, but those are the things that I think are going to prevent this from happening again in the future.
One additional question on technology. So clearly you're using the Demaji platform. There's been a lot of discussion and in news recently by tech giants and other firms kind of coming forward with cell phone-based contact tracing, text alert oriented solutions, which stands in contrast a bit to the kind of brute force, human-centered model you guys have deployed here, obviously with technology. Any thoughts on how these two different kinds of approaches might come together, or is it just going to be different approaches in different settings?
I think that's a great question. And I have been hearing a lot about that as well. And I think it's going to be a multitude of solutions, honestly, because right now we're in shelter in place. We're seeing really hard hit and vulnerable communities. That's where our attentions need to be. The Department of Public Health the public sector is going to be the key service provider and being able to really help those communities at the moment. But as the shelter in place lifts, I think it's going to shift. And so we're going to see a lot more people in a lot of other settings. They're going back to work, they're going back to school. And so they may be more affluent. So maybe for some groups, the phone technology might help. And for people to, or not even that, maybe just simple text messages. When people are positive, they text their friends who are in stable situations and can self-isolate well or self-quarantine well. And so they kind of take care of it very quickly. So I think I wouldn't be dismissive of other technologies. I think they're just going to all kind of gear and play in a different role. Some are coming into place to really help workplaces, large workplaces like an IKEA or Crate and Barrel, to be able to get their workforce back in line and be able to monitor them and their exposures, and if someone's positive within those communities. So kind of alleviating maybe some of the burden on Department of Public Health. So I think technology is just going to branch out a lot as we lift the shelter in place.
Great. Thank you, Michelle. One other question here is around, back to the volunteering point, liability considerations. So apparently some people on the webinar have indicated in other counties their efforts to volunteer have been rebuffed by liability concerns. And I'm wondering if there's some sort of unique element to the SFDPH UCSF arrangement that protected you from that.
We actually have a contract with SFDPH. So we're under that contract. I think there's a clause that will be handling protected health information. And as we bring in other city employees, I think that is one reason. So I think SFDPH has a lot of constraints around ability to use volunteers because of that reason. So I think we actually have a contract to do this work. So.
And other places might not. And that, again, back to the a suggestion for consideration on the dissemination point that I didn't want to lose here, but someone suggested starting with the other UC campuses where many of them have medical schools and the opportunity to kind of partner with local counties under some sort of broader umbrella arrangement might be a way to start to roll this out in a context where we have a little bit more control and influence. So that's something to reflect on.
Yeah, I think it's a good thought. I want to sort of highlight an asset of IGHS, which is that we have a workforce of folks that are really nimble and agile. They're not constrained by like some of the academic infrastructure of other UC schools, etc. And I think that has afforded us the opportunity to jump into this in a way that maybe other institutions might not be. I also, as I said before, I think we just have a phenomenally talented group of people here. I hope other UC schools have the same caliber of folks that we do.
Right. One last question, and then I'll turn it back to Jaime to wrap up, if that's okay, and just thank the panel for their incredible work and presentation. A couple of questions related around partnerships, and I'm just wondering how much control you guys have had over the partners that you've worked with on this, whether it be the technology partner like CommCare or social service partners for housing and other services. Are those all determined through the city and through the county, or are they things that have been influenced or shaped by IGHS?
So they're all informed by the city. I would say that both Michelle and I sort of were in on the process of sourcing a vendor for the tech solution right from the beginning. So that afforded us the chance to kind of really understand it. But that was a partnership that SFDPH led on. And similarly, all of the other partnerships that are going on in the city are partnerships that are curated by SFDPH, not UCSF.
Right. So we're in a support role, building the capacity of the county public health, as opposed to making these calls, but an influential role. Great. We did our best to try to get through as many questions as you guys posted. Thank you all for doing that. We will also, for many people asked whether there will be a recording of this posted, and we will have that on the IGHS website as soon as we can download it and edit it to make sure it works. So please, if you missed anything here, please feel free to go to our website, the Global Health Sciences website, and find a link. With that, I'll just turn it back to Jaime for any sort of parting comments before we wrap it one.
Thank you, Colin. Quick question for Lucia and one for Mike. Regarding the disproportionate number of Latinos that have been affected, Lucia, you alluded to cases in San Francisco. There's a Los Angeles Times report on deaths and the proportion of deaths that have occurred among Latinx in California. 61% of deaths in the age group 18 to 49. Why do you think that is the case? Is there a genetic predisposition? Is this a social determinant? Or is it the comorbidities, diabetes, obesity, that Latinos often have in that age group? That's for Lucia. For Mike or Jess, so we have 105 contact tracers, almost half of which come from IGHS. Bravo. What proportion of the old San Francisco Department of Public Health come from UCSF? How many more contact tracers are there working in San Francisco now? Lucia?
Yeah, so that's a very good question. And I think that's a question not only us that we have, but also people in the Hispanic and Latinx community has been asking. And I guess for young Black people in other communities, San Francisco has a very small Black community, so that's why we're not seeing the same things as other places. So first of all, it's not genetic predisposition. So let's erase that idea from our heads. It's not that I as a Mexican are more vulnerable for COVID-19. I think it's a mix of social determinants of health plus the comorbidities, but we should also recognize that many of these comorbidities are also a result of social determinants of health. So why do we have more hypertension, more uncontrolled hypertension? Why do people in the Latinx community have uncontrolled diabetes in a bigger range, in a larger prevalence than other demographics? So yes, we've seen, and this has been seen in New York, people with obesity, people with diabetes, hypertension, are at a higher risk of developing severe COVID-19 disease. And as we know, that people that develop severe COVID-19 disease are more likely to die. And the same with Black people, we see a higher rate of uncontrolled hypertension, so very similar to the Latinx community. And we should also know that it all comes up from a lack of healthcare access, just their vulnerable situations. And right now, another reason is that they're getting infected in a bigger rate than people in other demographics. So, for example, if I'll just give like an example from the work I'm doing. In San Francisco, if I call somebody in English and they're middle-aged, white, they usually live with their partner and maybe 1 or 2 children. But if I speak to somebody from the Latinx community, they usually live with bigger households, and people are usually going to work more. So that increases the risk of infection. And so they have an increased risk of infection, but they also have an increased risk of severe disease. So that's why we're seeing also an increased risk of deaths.
Thank you. Jess or Mike? Yes?
Yeah, I can just answer quickly. So there are no other contact tracers, UCSF contact tracers within SFDPH to my knowledge right now. And the 44 IGHS, I can't say enough. Like, those people have helped us build this platform. It's really because of, you know, people who have stepped up and really made it work, that we're so grateful. I will say, however, that we are, you know, having to move. It's really has to be SFDPH owned and run. And we will be shifting our folks off to make room for the workforce that needs to take this on, that needs to own this, and needs to bring it to the next level. Hopefully we'll still be involved as supports and, you know, be able to step in as needed, but that's the vision.
Thank you, Jess. Well, thank you, everyone. We are a couple minutes over time. Wonderful, wonderful work. Congratulations to all 7 speakers. And please be ready to present in the UCSF-wide next town hall. And I will be in touch with you about this. Thank you again so much for a wonderful series. This is a great start. Goodbye, everyone.